Mastering Peripheral Arterial Disease. Q&A. Welcome to today's episode of the Everything Surgery podcast, where we'll be diving into one of the most important topics in general surgery, peripheral arterial disease, or PAD. Pause video when you hear the word answer to attempt answer. Let's get started. Basic concepts and pathophysiology. Question: what exactly is peripheral arterial disease? PAD? Answer: peripheral arterial disease is a chronic atherosclerotic condition that causes narrowing or blockage of arteries outside the heart, most commonly in the lower extremities. Question: where do we most frequently find arterial blockages in peripheral arterial disease? Answer: the superficial femoral artery, SFA, particularly at the adductor hiatus, is the most common site. Question: can you explain the Fontaine classification for peripheral arterial disease? Answer: certainly. Fontaine classification breaks down peripheral arterial disease into stages. Stage 1, asymptomatic. Stage 2, mild claudication, walking, 200 m. Stage 2b, severe claudication, walking, 200 m. Stage 3, ischemic rest pain. Stage 4, ulceration or gangrene. Question: what about the Rutherford classification? Answer: the Rutherford classification, 0-6, offers a more detailed grading based on symptoms and hemodynamic data. Question: what's the hallmark symptom of peripheral arterial disease? Answer: intermittent claudication, pain or cramping in the legs when walking, relieved by rest. Question: what defines critical limb ischemia? Answer: critical limb ischemia is severe arterial insufficiency, classified as Fontaine stage 3 or 4, or Rutherford 4-6, presenting with rest pain, ulcers, or gangrene. Question: what is the 5-year mortality rate for critical limb ischemia? Answer: it's approximately 50%, largely due to associated cardiovascular disease. Question: how is the ankle brachial index, ABI, calculated and interpreted? Answer: the ABI is the highest ankle pressure, dorsalis pedis or posterior tibial divided by the highest brachial pressure. Normal values are 1.0 to 1.4. Peripheral arterial disease is indicated by 0.7, useful when ABI is unreliable due to vessel calcification. Diagnosis and imaging. Question: what's the first-line diagnostic test for peripheral arterial disease? Answer: the ABI is non-invasive, cost-effective, and serves as our first-line test. Question: how do segmental pressures help us? Answer: segmental pressures localize disease. More than a 20 mmHg drop between segments typically indicates stenosis. Question: what's the role of duplex ultrasound? Answer: duplex ultrasound assesses stenosis, occlusion, and plaque, and is valuable for post-intervention follow-up. Question: when should we consider CT angiography? CTA? Answer: CTA is ideal for preoperative planning, especially with heavily calcified vessels. Question: when is MR angiography, MRA, preferred? Answer: for patients with contrast allergies or renal insufficiency, although there's a risk of nephrogenic systemic fibrosis with gadolinium in advanced CKD. Question: what remains the gold standard for imaging? Answer: digital subtraction angiography, DSA, which provides the highest resolution, albeit it's invasive. Question: what is Berger's test? Answer: elevating the legs to 45 degrees. If pallor appears, it suggests arterial insufficiency. Dependent rubor, redness, signals severe peripheral arterial disease. Medical management. Question: what are the pillars of medical therapy for peripheral arterial disease? Answer: smoking cessation, statins, antiplatelets, aspirin or clopidogrel, and structured exercise. Question: how important are statins in peripheral arterial disease? Answer: very important. Goal LDL is less than 70 mg/dL, which reduces cardiovascular risk and may improve walking distance. Question: which antiplatelet agent is preferred for symptomatic peripheral arterial disease? Answer: clopidogrel, as shown in the Capri trial, or aspirin. Dual therapy may be used post-revascularization. Question: does cilostazol help with claudication? Answer: yes. It's a PDE3 inhibitor that improves walking distance but is contraindicated in heart failure. Question: is pentoxifylline effective? Answer: it's less effective than cilostazol, considered second line for claudication. Question: what exercise regimen do you advise for claudicants? Answer: supervised treadmill walking, 3 times a week for 30-60 minutes per session. Question: any role for ACE inhibitors? Answer: Ramipril, based on the HOPE trial, reduces cardiovascular events but doesn't improve claudication itself. Question: what is the blood pressure goal for peripheral arterial disease patients? Answer: less than 140/90 mmHg, or less than 130/80 if they have diabetes or CKD. Endovascular management. Question: when is endovascular therapy indicated? Answer: for lifestyle-limiting claudication unresponsive to medical therapy or for critical limb ischemia. Rutherford 4-6. Question: how effective is femoropopliteal stenting at 1 year? Answer: primary patency rates hover around 70 to 80% for focal lesions. Question: what is a drug-coated balloon? DCB. And why is it used? Answer: it's a balloon coated with paclitaxel to reduce restenosis compared to plain angioplasty. Question: is there any controversy with drug-coated devices? Answer: yes. Some studies suggest increased mortality at 2-5 years, though recent data are mixed. Question: when is atherectomy considered? Answer: for calcified lesions, though there's no proven long-term benefit over plain angioplasty or stenting. Question: how does intravascular ultrasound, IVUS, help? Answer: IVUS improves stent sizing and detects dissections after angioplasty. Question: what does the TASC2 classification guide? Answer: it helps determine revascularization strategies. TASC A or B favor endovascular, while C or D favor surgery. Question: what is the complication rate for femoral artery access? Answer: approximately 2 to 5%, including hematoma, pseudoaneurysm, and retroperitoneal bleeding. Surgical management. Question: what's the gold standard surgical option for long SFA occlusions? Answer: femoropopliteal bypass, with a preference for vein grafts over prosthetics. Question: what are the 5-year patency rates for bypass grafts? Answer: around 70% for vein grafts and 50% for PTFE. Question: which conduit is best for infrainguinal bypass? Answer: great saphenous vein is preferred, followed by spliced vein, then PTFE. Question: when is a composite graft used? Answer: when there isn't enough vein length, a combination of vein and prosthetic is used. Question: why does the site of distal anastomosis matter? Answer: popliteal, above or below knee, and tibial targets impact long-term graft success. Question: what's the most common complication after bypass? Answer: graft thrombosis. Technical issues cause early thrombosis, and intimal hyperplasia causes late failures. Question: what is compartment syndrome post-revascularization? Answer: reperfusion injury can cause muscle edema and elevated compartment pressures, requiring urgent intervention. Question: how is acute graft thrombosis managed? Answer: with thrombectomy, possibly thrombolysis, or surgical revision. Question: when is endarterectomy indicated? Answer: for common femoral artery disease when endovascular therapy isn't an option. Question: what is a jump graft? Answer: it's a bypass extension to a more distal target when the primary graft fails. Question: what is profundoplasty? Answer: endarterectomy of the profunda femoris artery to improve collateral circulation. Acute limb ischemia. Ali. Question: what are the 6 classic P's of acute limb ischemia? Answer: pain, pallor, pulselessness, paresthesia, paralysis, and poikilothermia. Question: how do we classify Ali severity? Rutherford. Answer: Class 1, viable limb. Class 2A, threatened but salvageable. Class 2B, immediate revascularization needed. Class 3, irreversible, amputation required. Question: what is the first imaging you reach for in Ali? Answer: bedside Doppler ultrasound to confirm the absence of flow. Question: what is the initial management protocol? Answer: immediate IV heparin and urgent vascular surgery consultation. Question: when is catheter-directed thrombolysis an option? Answer: for Class 1 or 2 ischemia due to non-embolic thrombus, such as graft occlusion. Question: what about Fogarty catheter embolectomy? Answer: it's the first-line therapy for embolic Ali, such as from atrial fibrillation. Question: what are the risks of reperfusion syndrome? Answer: dangers include hyperkalemia, acidosis, myoglobinuria, and ARDS following revascularization. Amputation and wound care. Question: what's the most common level of amputation for CLE? Answer: below knee amputation, when tissue is viable. Question: when is a guillotine amputation used? Answer: in severe infection or necrosis, followed by definitive revision later. Question: How does wound vacuum therapy help? Answer. It enhances granulation tissue in chronic ulcer management. Question. What is the 1-year mortality after major amputation? Answer. Approximately 20 to 30%. Complications and follow-up question. What is a stent fracture? Answer. It's a mechanical failure, particularly in femoropopliteal stents, more likely with longer stents. Question. How do you manage in-stent restenosis? Answer. With drug-coated balloon angioplasty or atherectomy. Question. What's the role of surveillance duplex after bypass? Answer. Regular scans every 3-6 months help detect stenosis before graft occlusion. Question. What is the most common cause of late graft failure? Answer. Neointimal hyperplasia, typically peaking between 6 and 24 months post-surgery. Miscellaneous question. What is blue toe syndrome? Answer. It's caused by microembolization from proximal plaque, such as cholesterol emboli. Question. Can you describe Leriche syndrome? Answer. This is aortoiliac occlusion resulting in claudication, impotence, and absent femoral pulses. Question. What is popliteal artery entrapment syndrome? Answer. It's an anatomical compression of the popliteal artery, often seen in young athletes. Question. What is cystic adventitial disease? Answer. A rare disorder involving mucinous cysts within the arterial wall, leading to stenosis. That concludes our comprehensive review of peripheral arterial disease management. Please remember, early recognition and multidisciplinary care are vital for improving outcomes. Thank you for joining us, and stay tuned for more in-depth surgical discussions.